All right.
All right, everyone. This is Group 12's presentation for case study number 2. So our case study goes as follows. JD is a 57-year-old African-American male who is in the hospital for heart failure exacerbation. He currently is on lisinopril 10 milligrams daily, metoprolol, extended release 100 milligrams daily, and atorvastatin 80 milligrams daily. He is classified as having class 2 heart failure and is experiencing hypokalemia. The doctor also notices edema in his legs with pitting edema 2+. So we just went over the case problem. The purpose of this case study, so we want to redo the patient's medication regimen and control the symptoms of his heart failure. And we want to also decrease and manage his edema. So the goal of treatment, the patient will adjust and tolerate new medication. His edema will improve and daily activity will be tolerable. So some non-pharmacological measures we can do are increase exercise, so increase his daily activity gradually. Also consult with a dietitian for better eating habits. Healthier eating reduces sodium intake, which will result in less edema. We can track daily fluid, monitor intake and output, increase his potassium-rich foods in his diet, which will bring up his potassium levels. So diagnostic and management, the NICE 2018 guideline states that if the BNP level is above 400, the patient should be referred for an echocardiogram and a special assessment to be seen within 6 weeks. If above 2,000, the patient should be seen within 2 weeks. An ECG and an exercise stress test. And then symptoms of shortness of breath include persistent coughing, wheezing, edema, fatigue, lack of appetite, nausea, impaired thinking, increased heart rate. So we want to track symptoms, take medications as prescribed, decrease or eliminate alcohol and smoking, encourage a healthy diet, and begin exercise as tolerated. We'll go over to Amanda for the disease process.
Okay, hello, this is Amanda. Heart failure is a chronic progressive condition in which the heart muscle is unable to pump enough blood to meet the body's needs for blood and oxygen. So basically the heart can't keep up with its workload. At first, a patient's heart will try to make up for this by enlarging, so the heart stretches to contract more strongly and keep up with the demand to pump more blood. Over time, this causes the heart to become enlarged, and it will develop more muscle mass because of the greater contractility of the heart. So the muscle mass grows, and the heart pumps faster, which helps increase the heart's output. So these compensatory mechanisms are temporary measures to mask the problem of heart failure, but they don't solve it. Heart failure continues to worsen until the compensatory mechanisms are no longer working. So eventually the heart and body just can't keep up, and the person experiences the fatigue, breathing problems, or other symptoms that usually prompt a trip into the clinic. So our patient has class 2 heart failure, which is a mild form of heart failure that places limitations on his physical activity. These patients may experience fatigue, dyspnea, palpitations with daily activities, and they get the most comfort and relief when they are at rest. Hypokalemia, which our patient has, is a decreased serum potassium level, which is less than 3.5. We would want to give this patient an ACE inhibitor, which blocks the conversion of angiotensin 1 to the vasoconstrictor angiotensin 2 and prevents the degradation of bradykinin and other vasodilatory prostaglandins, thus increasing plasma renin levels and decreasing aldosterone levels. A beta blocker will compete with adrenergic, which are sympathetic neurotransmitters, epi and norepi for adrenergic receptor sites. The beta-1 adrenergic receptor sites are located mainly in the heart, where stimulation results in increased heart rate and myocardial contractility. Beta 2 adrenergic receptors are found mainly in bronchial and vascular smooth muscle and the uterus. A statin will inhibit an enzyme involved in cholesterol synthesis, which will help. It will decrease blood lipids in an effort to reduce morbidities and mortality. Now I'll pass it over to Dusty Best, who will speak on the prescribed drugs.
Good evening. This is Dusty. I'm going to talk a little about our prescribed medications that our patient JD is already on. Amanda just went over those mechanisms of actions with you. We're going to talk about the daily dosing and potential medication alternatives because JD is currently at maximum on some of his medications. So when we look at lisinopril, which is our ACE inhibitor, it is recommended to do 2.5 to 5 milligrams once daily. As tolerated, they may increase 1 to 2 weeks, but no more than 10 milligram increments to target dose of 40 milligrams daily. In hospitalized patients, the dose may be titrated at 1 to 2 day intervals, less effective in Black patients, and cause a higher rate of angioedema. So when we touch on the ACE inhibitors, we do need to take into consideration that JD is an African American patient who is already at a 10 milligram a dose daily. So his increment could only be increased by 10 milligrams again daily. So he'd be able to go up 10 each. That may be a medication that we may be able to find an alternative to. When we look into the beta blockers, he's currently on metoprolol, and JD's taking the extended release 100 milligram daily. Our oral initial titration would be to be 12.5 to 25 milligrams once daily, and to titrate gradually to a maximum tolerated dose while monitoring for signs and symptoms of heart failure. We already know that JD's having those symptoms via his edema. Maximum dose of 200 milligrams a day in the stable patient. Studies do suggest that there are hydralazine and isoprostol nitrate could be added to his current regimen to decrease morbidity rates and mortality rates for the different stages of his heart failure. There have been reductions in the death during the advanced stages of heart failure, and JD is in class 2, which is one of the milder stages, but it would be something to monitor further on. He's also taking atorvastatin, which the initial dose would be 40 to 80 milligrams once daily. And if 40 milligrams once daily is initiated and tolerated, then it may increase to 80 milligrams. JD is already on 80 milligrams daily. So one of the things that we went over in our case study was to reference what medication regimen we may change for JD. Some of the things that we looked at again were the hydralazine and other options for the cardiac side. The bigger risk would be to alleviate the pressure of the fluid accumulation. Currently, JD is taking a Lasix PO, and we are hospitalized. He's at a maximum of 200 milligrams every 8 hours. So one of our options would be to either start him on IV Lasix therapy or to change his drug regimen altogether and attempt possibly a Bumex diuretic. Still being a loop diuretic, it would help with potassium preservation and possibly alleviate his fluid accumulation. Some key points and conclusions that our group would like to put in, asked to the groups out there, are to ensure the correct medication for his ethnicity, being that he's an African American, and the dosage are given, monitored, and tapered correctly by the prescribing physician. To educate the patient on the signs and symptoms to watch for and when to report them. We don't want JD to go home as a class 2 still with asymptomatic and not come back until he's severely symptomatic. Encourage the patient to practice the non-pharmacological measures to avoid and aid in the reducing of symptoms for a better activities of daily living, which was covered in the beginning of our presentation. There are many things that he can do by tracking his own fluids at home, by monitoring his own dietary needs, and doing a daily exercise. Questions specifically would be, what is class 2 heart failure? You can review that in our previous statements. Should the prescribing physician consider changing medication regimens because of the special population? Also reviewed above, as you can see. What adverse reactions should be reported? Part of the key conclusions are things that JD needs to watch for, and in what way can this patient regain physical activity? Some of the limitations with physical activity and heart failure, as many of you have worked in hospitals know, that the edema can become quite significant and very debilitating. So it'd be important for him to go home and to be able to maintain his physical activity and to report when that is decreased. And that concludes our presentation. Thank you very much for taking the time to listen.